Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week summaries, which this week were brought to you by our authors, Caitlin Nicholson, Joshua Belfer, Amanda Matthews, Kitan Patel, Kyle Rankin, Shannon Marcus, and Clay Smith. So here is the first article titled Age-Adjusted D-Dimer Cutoff Levels to Rule Out Deep Vein Thrombosis. You heard me. This is out of the JAMA. Finally, I've been dying to do this for my patients for ages. I am so happy that this is here. Age-adjusted D-dimers for PEs have been out for a while now, and honestly, it's the same pathophysiology. The clots that cause PEs primarily come from DVTs, and so why wouldn't this also be useful for DVTs? It's a breakdown of fibrin products, which if it's in your leg or if it's in your heart, who cares? I guess maybe it's, who cares? You know what? Let's go on this one, and this is finally validated. Let's talk about the trial. This was a multinational prospective management study called Adjust DVT, which enrolled 3,200 emergency department patients. And it was across 27 centers from 4 countries. This is going to generalize pretty well. I'm happy with this. They determined a pretest probability using the Wells score, and then that's how they decided if they should just go straight to getting a Doppler or if they should do D-dimer testing. This is regular practice. Now, just a reminder, age-adjusted D-dimers means that if you're over the age of 50, then you multiply their age times 10, and that's going to give you their new D-dimer cutoff instead of 500 nanograms per liter. Now you can have a higher score. So if they're 75 years old, their new D-dimer cutoff is going to be 750. This is nice. This works. This is very well validated for pulmonary embolisms, and it's still very safe to use. Now, overall, using this strategy, this increased the overall number of negative D-dimers by 7.4%, but it had the biggest bang for buck in people who were over the age of 75, increasing the rate of negative D-dimers from about 9% to 26%. So this is way more patients that can go home. And importantly, none of these patients developed VTEs, and so this was really safe. This was great. Now, with any trial like this, there are still some failures of the D-dimer. D-dimer failed 1 patient truly and 11 patients who had distal DVTs, but we don't count those as clearly. What we saw was that at 3 months, because they did 3-month follow-up, someone with a negative D-dimer has a 0.2% chance of having a VTE over the next 3 months. So I'd say that's really good. And there's also some retrospective trials which look at this and also seem to show that it's safe. So that's multiple trials, and this big multi-center, multi-country prospective trial, I'm planning on using this. This was also with multiple different D-dimer assays too. This generalizes all over the place. I'm using this for my patients. In a spoonful, age-adjusted D-dimers are finally here for DVTs. Rejoice. Okay, then we skip to the 5th article, titled Necrotizing Soft Tissue Infection Survival Guide in Adult Patients, a Position Statement by the Global Alliance for Infections in Surgery, out of the Journal of Trauma and Acute Care Surgery. I love that they call this a survival guide, and it's about necrotizing infections. It makes it sound like it's some kind of zombie survival guide. That is wonderful. This is a review that is not by Britt Long. All right, so these guys got together and made a couple of recommendations about what you should know and how you should be treating patients with necrotizing soft tissue infections. This, of course, includes necrotizing fasciitis, which is the one that we think about the most, but also Fournier's gangrene, which is just a subset that's in the sort of pelvic area, and all the other things that are necrotizing and soft tissue infection. Now, just to start off, all the recommendations that they made are very low quality evidence, but some of them are strong recommendations because some of them are obvious. Now, the first recommendation that they made was to have multidisciplinary management. That's right, you should be having emergency medicine, surgery, ICU, and infectious diseases involved and involved early. Immediate debridement is so important for these patients. We're going to mention it again later because it saves lives. The next recommendation they make is that the diagnosis should be made as soon as possible. Duh. Delays increase mortality. Rapid progression is always suspicious for these patients. If you have a rapidly progressing soft tissue infection, you should think, hey, is this necrotizing? This is a red flag. Out of proportion pain is also an important sign, but keep in mind that it's not always going to be there, and that patients who are post-surgical, for example, can have a lot of pain. And that doesn't necessarily mean that it's a necrotizing infection. Or if your patient is altered or they have diabetic neuropathy or some other kind of neuropathy, they might not feel that pain out of proportion. So don't hang your hat on it. They say in order for you to raise your suspicion, you can use the Lorenic score, but use it with caution. It has terrible positive and negative predictive values, but very high scores are kind of specific. So, take it with a grain of salt. Now, the diagnosis is going to be primarily clinical, but they do recommend that you use labs and imaging to help you when you need, although neither of these things should delay the care of the patient. CT scans are going to be the best thing, and you're going to find the most early changes that you would otherwise possibly miss on POCUS. POCUS being another good option for these patients. It is up to 100% sensitive, with the most sensitive finding being fluid tracking along fascial planes, and subcutaneous emphysema being the most specific finding on POCUS. The authors do mention that MRIs are the absolute best imaging test, but impractical and likely not going to happen. Other options to help you are the finger test to see if you can make an incision, put your finger in there, and everything just separates easily. That's obviously a bad sign. Or frozen section biopsies. These can also be done, but you need a pathologist readily on call and you don't want to make any delays. So that one's done rarely. In terms of treatment, immediate surgical debridement is very important. The authors actually say that they try to avoid amputations as much as possible because it's not shown to improve outcomes as long as you're doing a good debridement. You should start with broad-spectrum antibiotics as early as you can, aggressive organ supportive care, and then you need to go back in for surgery at least every 24 hours until all of the soft tissue looks viable. They talk a little bit about the classification of this. This is more of a board exam thing. Type 1 is multimicrobial, type 2 is strep or staph, type 3 is marine organisms, and type 4 is fungal. Now, how about those antibiotics? You should start with broad-spectrum antibiotics covering gram-positives, gram-negatives, and anaerobes as soon as possible. You should consider adding in vancomycin depending on your local MRSA prevalence. Clindamycin is particularly useful if the patient has group A strep, but no matter what, clindamycin or linezolid should be started up front because it can help with suppressing the toxin production by these bacteria, primarily group A strep. Hyperbaric oxygen can be considered if it's available as long as it's not interfering with the other care. IVIG can also be helpful, but primarily specifically for group A strep in patients who have toxic shock syndrome. Now, of course, the journey of the patient is certainly not going to stop there. These patients have very long recoveries. It is very difficult for them. They have a lot of ongoing functional disabilities and cosmetic problems as well, but we're going to stick with the emergency department stuff. So in a spoonful, that was a review of necrotizing soft tissue infections. All that you really need to know is a very deadly condition. Call for help early. Okay, that's all the articles from this week. Let's do a quick wrap up of everything we talked about. From the first article, I wholeheartedly welcome an age-adjusted D-dimer approach to the rule out of DVTs. And then from the fifth article, we gave you the lowdown on necrotizing soft tissue infections. Remember, early surgical debridement, broad-spectrum antibiotics, and get a whole team involved. If you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were the articles that you missed about? Well, we did a review of brief resolved unexplained events. We talked about using different types of insulin, not just insulin regular for shifting potassium. And then we had a look at the risk tools for upper GI bleeds and testing out News 2 for that indication. Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.